that's one of the things we see commonly from patients who are singers or actors, and they've been referred for surgery, and they're very interested in RFA as an alternative to that because they're just so scared of losing their voice.
It is probably the one thing that I worry about the most in surgery.
I'm
Because
sure.
it's the most immediate and I think it has the most impact on someone's life
Yeah.
and well-being. Because your voice is you, right? It's part of your identity. Then we talk about the parathyroids. There's 4 glands, inferior and inferior on both sides. They're very, very small. We say grain of rice are a little bit bigger than that. I call them lentils. They're like little lentils. There's 4 of them. You only really need 1, but you have 4. Thank goodness. You have a little redundancy. And you have about a 2% chance of prolonged low calcium. So the parathyroid glands control your calcium level at a very tight. If they notice that your calcium is going a little bit low, then they'll bump up the parathyroid hormone, and that helps you retain your calcium into your blood. And then opposite, if your calcium is high, then the PTH will go low. So they get shocked during surgery. You can only get it on a total thyroidectomy or a completion. If you leave 2 alone, you're going to be fine. If you're bothering only 2, then you're not going to have to worry about it. But so you do a total thyroidectomy or a completion thyroidectomy, if they are damaged or shocked or removed or destroyed, you can get what's called a profound hypocalcemia, low calcium due to low PTH. And it's about 2% of people will have this prolonged, serious low calcium. 2% is a lot, if you ask me. And I'm talking about lots of high doses of calcium during the day, and some special medicine called calcitriol, which is a strong vitamin D analog that helps you absorb the calcium better. And the symptoms of low calcium are numbness and tingling in the lips and fingertips. Not dangerous, kind of tells you there's something wrong. Cramping is dangerous. Once you start cramping, that can cause heart arrhythmias, and it can cause your voice box to close. We call a laryngospasm, and then you can't breathe, and it can be dangerous in that way. So
my goodness.
That's extremely rare. So almost everybody who gets a total thyroidectomy will have an asymptomatic, unclinical, lower calcium. Almost everybody will be sent home on some calcium just to prevent that drop. And occasionally people are brought into the, if the calcium is going too low, they're brought into the hospital for just calcium maintenance.
Okay. Well, those are all important things to discuss. And as you said, the risks of those happening are very, very small percentages. And, which is good. We want to make sure that is, as low as possible when we're going to choose to have surgery. However, as we kind of now go into the topic of radiofrequency, are those risks even lower with radiofrequency?
They're very much lower. That's the one thing those are the biggest advantages of radiofrequency ablation. It's minimally invasive. It's a day procedure. You go home, you should have almost no restrictions the day that the procedure is done. The risk of hypoparathyroidism and low calcium is, I hate to say 0, but it's kind of close to 0. And if you're not mucking around with the area below, underneath the thyroid, you're not going to be messing with the parathyroids.
Yeah.
So it would be that's almost a non-starter. And then the risk of low thyroid hormone, also extremely low. Whenever you are reducing the volume of thyroid tissue, there's always that risk. The whole idea is you don't know how much thyroid hormone your nodules are making. Typically, if you still have viable, normal thyroid tissue around your nodules. So if you're only ablating a nodule, you're not touching any of that normal tissue, your risk of hypothyroidism is extremely low. And the biggest risk, the thing that I worry about the most for serious side effects is the nerve still. And you can transiently heat up the nerve, and it can get bothered. It depends on anatomy, where the nodule is, where it extends, how close is it to the nerve. We do have some safety protocols in place to help try to preserve nerve function. If you've got a nodule and the nerve is right next to it, we're not going to ablate next to that. We'll leave that area of the nodule alone.